My name is Joe Knapp, and I'll be walking you through your final station case study number 2.
For case study number 2, we have an approximately 30-year-old female who weighs 59 kilograms. She's admitted after sustaining 51.5% TBSA, primarily full-thickness thermal burns after setting herself on fire with gasoline. She has burns to the face, neck, bilateral arms, chest, abdomen, back, and bilateral anterior thighs. The burns to the torso and bilateral arms are circumferential. And for question number 1, due to the circumferential full-thickness burns to her arms, what is the appropriate plan of care? Check all that apply. The correct answers to question number 1 are A. Elevate arms on 2 IV poles, and D. Check radial Doppler pulses every hour. Elevating the arms on IV poles decreases edema and increases venous return. In circumferential full-thickness burns, always radial Doppler pulses every hour, and if pulses are absent, promptly notify the physician or attending. Question number 2. A burn inhalation injury was confirmed after bronchoscopy. What order set should be utilized based on this finding? The answer to question number 2 is A. Aerosolized heparin, albuterol, and acetylcysteine breathing treatments. For question number 3, get out your calculators. Please calculate the total 24-hour fluid requirement for this patient using the consensus formula. The answer to question 3 is D, 6,077 milliliters. We arrived at this answer using the consensus formula, which is 2 milliliters times weight in kilograms, which is 59, times TBSA, which is 51.5. Question number 4. Based on the consensus formula, at what rate should the Ringer's lactate run at initially? She was burned approximately 2 hours prior to arrival and received 1 liter Ringer's lactate in the field. The answer to question 4 is C, 340 milliliters per hour. We arrived at this number by taking into account that the patient's fluid requirements per hour start from time of injury, not time of arrival. And we must also take into account the patient received 1 liter of Ringer's lactate in the field. The first half of the total fluid, 6,077 milliliters, should be given within the first 8 hours from time of injury. So we take 6,077 milliliters divided by 2, which gives us a total of 3,038.5 milliliters. We then subtract 1 liter from the total 3,038.5 milliliters, which gives us a total of 2,038.5 milliliters. And then, taking into account the 2 hours which have passed since the patient's time of injury to time of arrival. So we take 2,038.5 milliliters and divide that by 6 hours. That should give you a total of 339.75 milliliters per hour, and rounding up very minimally to 340 milliliters per hour. Question number 5. It's been 12 hours since admission. Urine output was below 20 mLs per hour at 4 different time intervals, requiring increases in fluid rate to 1,000 milliliters per hour. Urine output is now adequate, but remains at only 30 milliliters per hour. What would be the next appropriate intervention? answer to question 5 is B. Call the doctor to request colloid rescue with 5% albumin. The rationale here is that once you have reached the 1,000 milliliters per hour mark, based on this patient's fluid calculations, you have surpassed the 1.5 times the calculated rate and also the 6 mLs per kilo per TBSA. That should trigger you to ask the physician for colloid rescue with albumin. Question number 6. The doctor agrees to do colloid rescue per surgical critical care guidelines with 5% albumin. What is the correct rate at which each fluid should run? The answer to question 6 is A. 333 milliliters per hour of 5% albumin plus 660 mLs per hour of lactated ringers. Per surgical critical care guidelines, colloid rescue involves 1/3 the calculated rate of 5% albumin and 2/3 the calculated rate of lactated ringers. Question number 7. The patient's urine output decreases to 20 milliliters per hour despite colloid rescue. The patient's abdomen is now firm and peak ventilator pressures have been alarming. However, the patient does appear to be adequately sedated. Based on this assessment, what is the next step? Select all that apply. The answer to question 7 is B. Check bladder scan for retention, C. Pass the information on to the RT, and D. Obtain an order to check an abdominal pressure. While increasing sedation may decrease the ventilator pressure alarms, physical assessment is noted of the patient's abdomen now being firm. Repositioning the patient may temporarily relieve those ventilator pressure alarms. However, understanding that your physical assessment is most important and identifying that a firm abdomen and high ventilator pressure alarms is a strong indicator to do several things. Check the bladder scan for retention, obtain an abdominal pressure, and always communicate ventilator issues with your respiratory therapist. Question number 8. The bladder scan showed urinary retention, which resolved after obtaining an abdominal pressure. Intra-abdominal pressure was 12, and urine output is now 40 milliliters per hour. However, the peak pressure alarm continues. The patient's oxygen saturation remains at 100% on 30% FiO2. What would be your next intervention? And remember, keep in mind the location of the patient's burns. The answer to question 8 is A. Call the doctor to evaluate for thoracic compartment syndrome, keeping in mind the patient's circumferential thoracic burns. Please keep in mind, B is not an appropriate answer because the patient appeared to be sedated. C is not an appropriate answer because the alarm parameters are there for safety. And D is not an appropriate answer because the patient is saturating at 100% on minimal oxygen. Question number 9. It's now been 4 days since the patient was admitted. The patient has been intermittently febrile since admission, but now her heart rate has increased from 110 to 130 beats per minute over the last few hours, and is hypertensive despite no apparent agitation. What orders should the RN expect? The answer to question 9 is B. Blood cultures times 2, empiric antibiotics, and an arterial lactic acid level. Please consult with the Orlando Health Sepsis Bundle guidelines, as a fluid bolus in this case is not appropriate due to the patient being in the hyperdynamic stage of sepsis, indicating that the patient is tachycardic as well as hypertensive. Question number 10. Consider if the patient was hyperthermic 2 days post-burn injury, what nursing interventions would you consider? Blood cultures in this case may be inappropriate due to the fact that the patient has not had enough time to reach the prodromal stages of sepsis. Several considerations in the hyperthermic 2 days post-burn injury patient would be the physiologic metabolic response to that patient's injury, the amount of skin exposed, the location of the temperature check, as well as environmental modification. Several tools that can be utilized to bring down the patient's temperature include Tylenol, as well as ibuprofen, if appropriate, and approved by the burn attending. Ice packs and cooling blankets are also good to use on unburned, ungrafted skin. However, always confirm with the burn attending if this is appropriate and communicate that to the team throughout the patient's care. And last but not least, the patient usually uses this catheter to warm them. However, a Thermoguard catheter should be one of the last resorts, as it is the most invasive of all these options. Question number 11. After contacting the resident, no new orders were obtained despite your concerns of the patient being septic. What is your next step? The correct answer to question 11 would be C, escalate the chain of command according to policy number 0350. And that was the last question of the last station at the 2018 Orlando Health Burn Skills Fair. Thanks for watching.